And on behalf of EIZOC, I welcome you all to the 24th Ophthalmology Resident Training Series. Today's topic we have evaluation
recording in progress
and approach to orbital tumors. And speaker for today is Dr. E. Ravindra Mohan, who is the honorary professor of MGR University from Chennai and an old friend of mine. He used to come to Patna before COVID times. The webinar will be moderated by Dr. Vigyan Panda, and we have a panelists in Dr. Anirban Bhaduri, Dr. Jayita Das, Dr. Varsa B, and Dr. Rajesh Chaudhary. And the discussants we have PGs and residents from different medical colleges of the East and beyond. And at this point, I must thank our mentor, Dr. Ajit Babu Manji, who has done a meticulous job, along with Dr. BNR Subuddhi, who is the chief coordinator of this program. And I also wish to thank Dr. Swaraj Bhattacharya, the secretary, and Dr. Sabyasachi Patnaik, the chairman scientific committee of EIZOC. I would also like to inform that we have our annual conference at Kalimpong, which is coming up on November 29th, 30th, and December 1st. So I request all of you, all of the viewers, to join the annual conference. And with these words, I welcome the entire audience. We'll have a very, very informative talk from Dr. E. Ravindra Mohan. Over to the chief coordinator of the program, Dr. BNR Subuddhi, sir. Over to you, sir.
Good evening. Respected President Dr. Pranav Ranjanji and our mentor Dr. Ajit Babu, incoming President Dr. Jayant Borwa, and all the EIZOC members. I welcome you all to today's program. Let me share the screen. As you know, yes, I think my screen is visible.
Yes. Yeah, your screen is
I'm audible also.
The slideshow.
Yes. So this is our 24 session of ORTS program under the platform of EIZOC. And today's topic is evaluation of proptosis and approach to orbital tumors. So none other than the famous oculoplastic surgeon, Dr. E. Ravindra Mohan. And our team always with me, Dr. Pranav Ranjan, President of EIZOC, Dr. Swaraj Bhattacharya, Secretary EIZOC and Chairman Scientific Committee, Dr. Sabyasachi Patnaik. Dr. Sabyasachi Patnaik, our Chairman Scientific Committee, will be joining shortly. And mentor, as you know, he spends a lot of time sparing from his valuable, clinical work and academic work. He gives us, for us, not only for the Odisha, but all the EIZOC states. So welcome you, sir, Dr. Ajit Babu Maji. And, coordinating the program is really, no doubt, is a tough task, but I do very meticulously. And today's speaker is none other than Dr. E. Ravindra Mohan ji. He is honorary adjunct professor, Tamil Nadu MGR University, Chennai. To tell a few words about him, I think some of us know him very well. And he presently is the founder director, Trinatra Eye Care, Nungambakkam, Chennai. Also is a senior consultant, MGM Healthcare, Chennai, Glengals Global Health City, Chennai, and Palmer Shankar Eye Hospital, Chennai. He completed his MBBS from AIIMS, Delhi, and after that he completed his MD from also RP Center. And following this, he worked as a senior resident and senior register in the division of oculoplasty, orbital surgery, and pediatric ophthalmology at the AIIMS for 3 years. After that, he joined Shankar Nethralaya as a consultant and is appointed the head of the department and director of department of oculoplasty, orbital surgery, and trauma in April 2005 till 2005. Then he left Shankar Nethralaya to start his Trinatra Eye Care at Nungambakkam, Chennai. He has over 100 paper presentations, over a dozen poster and video presentations, and delivered over 200 invited talks, including named orations. He has over 24 publications to his credit, including those in prestigious journals like Survey of Ophthalmology, Eye, Orbit, Ophthalmic Practice, Ophthalmic Plastic, and Reconstructive Surgery. And Indian Journal of Ophthalmology has also some book chapters. He has performed life surgery at a number of national and international meetings and been a chief instructor at a number of innovative instruction courses. He has been an executive member and secretary of the Oculoplasty Association of India, advisor for appointments to various senior ophthalmologist positions in the government of India. He has been a surgeon to the governor of Tamil Nadu and also invited surgeon for the government of the President of India. He is a reviewer for a number of index journals, including the Indian Journal of Ophthalmology, Ophthalmic Journal of American Academy of Ophthalmology, Middle East African Journal of Ophthalmology, and Ophthalmic Plastic and Reconstructive Surgery. These few I have selected from his views, biodata he has sent to me. So welcome you, sir, for this program. Today's program, we would love to listen about your expertise on the proptosis and orbital tumors. Today's moderator is Dr. Bigya Panda. She is the assistant professor at AIMS Bhubaneswar, and a panel consisting of Dr. Anirban Bhaduri, currently at the Oculoplasty Ocular Oncology Service of Susrutai Foundation, Salt Lake, Kolkata. Dr. Jaita Das, senior consultant Oculoplasty and orbital surgeon at Desai Hospital, Kolkata. Dr. Varsha B, currently she is an orbital oculoplasty surgeon at Sankaranathara, Chennai. And Dr. Rajesh Chaudhary, currently senior consultant of Netralayam. He is always with us in some of our programs of ORTS. And today's discussions, we got a number of discussions, more than 10. Dr. Purbasa Panda from Himsar Burla, Dr. Sasmita Mishra from Himsar Burla, Dr. Pankaj Shukla from JLN Medical College, Bhagalpur, Dr. Zakia Nurjat from Jawaharlal Nehru Medical College, Bhagalpur, Dr. Debajit Deka, Silchar Medical College Hospital, Dr. Surabhi Prasad, Silchar Medical College Hospital, Dr. Mansa from MKC Medical College Hospital, Dr. Satrupa Das, RIO Kolkata, Dr. Sadab Qadri, MKC Medical College Hospital, and Dr. Rishabh Seth from Ruby Hospital, Barampur. So these are the discussions. In the next few minutes, they will be discussing the topic with the speaker, moderator, and the panelists. So these few words, I welcome you all to today's program, and I now hand over the mic to Dr. Bigya Panda to continue the session. So it is Dr. Bigya Panda, continue the session, please.
Thank you, sir. Thank you, sir, for the kind introduction. So I also welcome you all, respected senior faculty members, senior members of the EIZOC, our esteemed speaker, sir, Dr. Ravindra Mohan, sir, and our esteemed panelists, and my dear postgraduates. So as you all know that proptosis is a very important topic, it comes as a long case in your exams and also as a long question or a short note in your theory exams. And I have seen my residents, whenever a case of proptosis comes to the clinic, they just fear. Oh ma'am, we are not able to evaluate. So I think we have a very eminent speaker with us, Dr. Ravindra Mohan, sir. He speaks so fluently and in such an easy manner that everybody can understand. I have personally attended many of his lectures. I have seen packed audiences, packed halls of people. So I request all the postgraduates to take advantage of this session. And at the end, we'll first listen to the lecture of sir, and then we'll take the questions at the end. And I expect at least one question from each postgraduate and at the end of the lecture. And if they don't ask, then I have a lot of questions to ask.
They can ask in between also. Only postgraduates can ask in between.
Okay. Granted. Okay, sir. Then without much delay, over to you, sir.
Yeah. Thank you, Dr. Bigya, and of course, Dr. Subuddhi and Dr. Ajit. Dr. Ajit has been my teacher and senior resident and a close friend for over 3 decades now. So it's truly an honor and a privilege to be speaking in this forum and to young postgraduates where we can certainly make some impact, in terms of teaching and giving something for them to carry through their professional careers. So with these words, I just start with the first talk. So actually what I thought was I was not very sure about the time and the pattern. So I've divided the talk into two parts. Part one is very basic. approach to proptosis. Like Madam mentioned about postgraduates getting scared and not able to organize what they know or etc. So I believe even in the DNB exam last week, there was a question on unilateral proptosis, and there were a total of 3 questions from oculoplasty in the papers. Some of them were fairly lengthy questions. So we'll definitely discuss these approaches of how to approach, how to look at a patient carefully, and the so-called Pandora's box and the mystery of orbit will become simpler, I hope, at the end of these talks. So the first talk is a simple introductory which outlines certain very important aspects. And the second part of the talk is about surgery itself, because I think that's important that we deal with some aspect of surgery. We didn't pack it with videos because I think diagrams and good pictures tell a better story, because sometimes the video doesn't play, and then we try to show our good work. That's not what a postgraduate wants to see. I mean, that's fine for getting awards and orations, but for postgraduates, I think it's important to stick very close to the subject matter. And so that's the second part of the test of the talk. So we could have the first talk, a break, interaction, and then the second part, or as Madam and Dr. Subudhi and Ajit feel perfect. So we'll start with the first part, and then we'll take things forward. Right. Now we come to the topic of orbit evaluation or evaluation of the proptosis. So, I mean, in terms of orbit, we are talking in terms of the structure, and proptosis is, of course, the clinical condition. Now, it's important for any postgraduate to start education in orbit with anatomy. I think we always started our medical school with anatomy, and we need to stick very close to it. The presence of the orbit within the skull, surrounded by the sinuses on 3 sides and by the brain just behind it, close association with the sinuses, and also the risk of injuries around the eye are all important facts when we come to evaluating or any kind of orbital disease or condition. So the close relationship of the orbit with sinuses, the maxillary, the ethmoid, and the sphenoid a little behind, and frontal has an important role in coming to a diagnosis in terms of orbital disease. Also, the fact that this is a porous kind of a wall which separates the orbit from the brain and meninges. So we know that the eye itself is an extension of the brain or neural tissue. So these relations become very important as we go. This is a side or sagittal view which shows the muscles and the close relationship between the sinuses here and the brain. So we can imagine the brain here, and this is all so close to each other, so that we need to really work very closely in a multidisciplinary approach to give good care to patients with orbital disease. So you may have the ENT surgeon, the neurosurgeon, the plastic surgeon, and a facial-maxillary surgeon. So all the people. So it's an area which is at the interface between all these specialties. Now, I start with history. One of the few areas in ophthalmology where history taking is detailed and vital. And advances in imaging seriously threaten this art. So, I mean, we always used to be told by our teachers that we are not taking adequate history, and now things have got much worse. The patient comes with a scan advice somewhere, and the postgraduate who's standing with you and in your clinic first opens the scan and says, "Oh, sir, this is this." So this art of history taking must not be forgotten. And I think if you are fortunate to get a case with orbital condition, thyroid eye disease, or in one of the tumors, then I think it becomes very good if you are a good history taker and you've been a good student, meticulous in your approach, to easily do very well in these cases. Now, why do we take history in orbital disease? Why is it important? For example, I must confess that I in cataract surgery, we don't take much history. It doesn't have too much of a role. Maybe the profession, maybe some little bit of things about the patient's background or expectations. But in the orbital disease is like neurology or some other psychiatry or neurology, in which we need to get into the natural history of the disease. Did the disease start suddenly? Was it sudden in onset? Was it slow, progressive? Did it wax and wane? For example, pseudotumor, there would be a typical history of waxing and waning of the symptoms. That would be a very, very important giveaway. whether it is congenital, inflammatory, vascular, malignant, all these things in history. Is there associated pain? Is there double vision? Has the vision dropped at any point of time? All these questions have to be asked. So if the history is inadequate, you're unlikely to come to a good diagnosis, a proper diagnosis. Of course, imaging helps, but we'll come later as to why imaging also is not the final answer. Now, involvement of nearby structures. For example, in a patient with a medial orbital mass, if we do not ask for ENT-related history, whether there has been a nose block, there has been epistaxis, whether there has been feeling that the nose is blocked, whether there is sinus disease, you are likely to miss many things and maybe even do something dangerous from the patient's outcome point of view. Also, whether the patient has severe headache or focal neurological deficit. There are conditions where the orbit may show proptosis, but there may be something going on inside the brain. And I think these things have to be looked at. So history of ENT disease, history of neurological symptoms, history of, for example, a patient with neurofibromatosis. It's very, very important that we ask a family history. And they would say, oh, yes, all of us have some spots here on the skin, like a cafe au lait spots. Also, those patients may have optic nerve glioma. So unless you ask and see carefully, you are likely to miss. And is any systemic disease causing it? So we need to know what is happening in terms of the patient. Thyroid disease, are there any autoimmune diseases? For example, the patient has renal disease and orbital disease. You may start thinking of vaginous granulomatosis. Many times, I think in my 30 years of clinical practice, many diagnoses have been missed in orbital disease because of lack of a good history. So I think it's very important. I would like to again re-emphasize to all our young postgraduates who are listening, please spend some time with the patient. This is not the routine redness of the eye or watery eye or even our routine cataract. Who doesn't need so much time? Those patients don't need so much of our time. We have a clear diagnosis, our management is clear, the outcomes are good. But these are patients who need a lot more of our time, and I think we should prioritize that. Now, I think it's when we were postgraduates, we all used to make these cards of history card or a examination card. What all should we ask? That's good to start with, maybe in the first year of residency or much before the exam. You can have a list of all the questions to ask, ENT symptoms, neuro symptoms, skin symptoms, family history, what all are important. So all those, but it can be a little tailored. For example, when we see the patient, we know it's thyroid eye disease. I think it's not very sensible asking the whole ENT gamut. We should ask about symptoms of thyroid disease. Has there been weight loss? Has there been sweating? Has there been palpitations, increased sweating, weight loss? So we would like to tailor the history rather than one size fits all, like one of my teachers used to say, throwing a big fishing net to catch all the fish. So that possibly needs to be avoided as we grow in the profession. So maybe very young, starting off a career, it's good. At least you'll not miss anything. But over time, till you come to the exam stage, it should be tailored. Otherwise, your examiner is going to say, why did you ask for this? Can't you see it is thyroid eye disease? Why are you asking for all these rashes on the skin or pigmented spots on the skin, etc.? I think a negative history is very, very important because the same way as positive history is important. For example, we find something in the medial orbit or in the inferior orbit. It's important to rule out any sinus-related issues. So, and minute details need to be probed. So one of the favorite examples I give for this is the patient, for example, has been given steroids. And you say, did the proptosis improve with steroids? And the patient says, yes, I got better. I think we can't stop there. Patients with idiopathic orbital inflammation will have an exquisitely fast response. So how I ask, even last week I had a patient with idiopathic orbital inflammation and I still ask the same question. I said, you took the tablet at what time? They said, the doctor told me to take it in the afternoon. I took my first dose in the evening, 6 o'clock. I said, by what time did you start feeling better? He says, by the time, I think before going to bed, I was better. So it's exquisitely sensitive, exquisite response. That's point. Because even a lymphoma will respond to steroids. If a patient has a lymphoma, meningioma, those are all going to, because that edema component will come down and the patient will feel better. But in this, the response will be very fast and very complete. So typical idiopathic orbital inflammation will completely go away. After a week, patient will say, I didn't remember which eye was affected. So that is the minute detail to which you need to do. because there are no diagnostic tests for idiopathic orbital inflammation. It's just history. It's only your history and then some support from imaging, which makes you diagnose, prognosticate, treat, follow up all these patients. So it's very important to get into that level of detail. Also, patients' problems and perceptions. See, unlike cataract surgery, of course, I also do cataract surgery. So I know how gratifying it is on the first post-operative day or today, even the evening of surgery, to see the patient's joy on the face. Orbital surgery, orbital disease isn't that easy at most times. I mean, of course, once in a while, we'll take out a well circumcised tumor. The patient will be very happy, will be very happy. But there are many, many issues. So there could be double vision after surgery. There could be drop of vision, rare cases, loss of vision. And the condition may be a tumor and the patient needs to go have chemotherapy, radiation therapy. Sometimes the start of a very long journey. So it's important to know the patient. What is the profession? How many people are there in the family? What happens if the patient, it's a cancer? Does the patient go through treatment or do they run away because they can't afford it? If they are not able to afford, where do we treat them? So there are many, many aspects. I think it's important to spend time with these patients in finding out their perception as well. And rapport building. I think the last one is very, very important. In orbital surgery, despite enormous experience, complications do happen. And it is this rapport building in the initial stage, in the first consultation, the second consultation, when you build up the rapport, that is going to save you from needing to hire a lawyer. So it's very important to build rapport. And I think patients are always grateful and remember the names of the doctors. Unlike in other specialties where sometimes the patient says, I can't remember the name, the doctor was a little short, so spend time with the patient in short, otherwise. Now, after having spent some time on history, we come to examination and orbital disease. So the question is there proptosis or is there enophthalmos? So is this eye proptosed or the other eye enophthalmic? Is the globe displaced? So we'll come to 2 or 3 things on this thing. The patient's perception is important most of the time because the patient sees themselves every day and there are other people who see them. So if they say that one eye is big, most of the time that is true. Unlike ptosis, where the confusion is a little more, we'll not get into that. Because there are conditions which cause enophthalmos. For example, the typical example which people say is of a breast carcinoma, scirrhus kind of breast carcinoma metastasizes and causes enophthalmos instead of proptosis. And is there a globe displacement? The globe cannot, so proptosis is axial or it's protrusion of the eyeball. So there can be displacement up, down, medial, lateral. So it's important to do inspection. We'll come to a few pictures and then I do not know whether postgraduates would be able to answer or how they would be able to answer these questions. So we have inspection, most important. In orbital examination, inspection is the most important. Palpation is important, but much less. Percussion, no role. Auscultation only in that occasional bruit which you may get. Otherwise, it's inspection, 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 and inspection, and a little bit of palpation. Then, of course, we come to exophthalmometry. We'll come to that in a moment. And all postgraduates, I would advise, at least those posted with me, to carry 2 clear plastic scales. The 30 centimeter scales, because sometimes when you ask them, nobody has it, they go to some other room, then they go to the office and then they get a scale. I think that shouldn't happen. 2 plastic scales, maybe 10 or 20 rupees each, is there in your examination pouch. And that will stand you in good stead even till your final examinations or even beyond that, because you need the 2 scales to see whether there's upward and downward displacement or medial and lateral displacement. Now we come to a few questions here. For example, we have this girl with a very, very mild proptosis. This girl had symptoms of very mild proptosis and some double vision on looking inwards. So is there anybody who sees both the, I mean, we're exposing you to imaging as well, so that's fine because the proptosis is mild. Is there anybody who can tell us what they see?
No, anybody asked by name?
I don't have the names here, unfortunately.
Dr. Shashmita Mishra. Dr. Pankaj Shukla.
Yes, sir. There is a mark in intra-orbital.
Turn on your video, no? It's always better to see your face.
Yes, sir.
Yes. Yeah, now you can go on.
So in CT scan, there is mass in intraorbital region, and I think, sorry.
You can describe what else. I mean, I said there's a mild proptosis on one side with some, double vision on looking in, looking to one side. So, I mean, since the picture will not show so much, let's concentrate on the CT scan. So, where is the abnormality? What number is written on the area of abnormality? Right. This is the abnormality. Which muscle? Yeah, which muscle is likely to be here? When we talked about double vision, medial rectus, right? So there's some lesion in the medial rectus. It is quite posterior. So if this is the medial rectus, is it in the tendon or is it in the belly? It's within the muscle, within the muscle itself, and pushing the eyeball a little bit. But this basically has a cystic look. And in our country, myocystic sarcosis is common. The scolex isn't made out all that well all the time. But in a patient, young patient, double vision, limitation of movement, a mass or a cyst, well-defined cyst in the medial rectus, it should be a myocystic sarcosis, and one would treat based on that diagnosis. Yeah. Now, at times, the proptosis can be so severe. So, can we have the next student, Sashmita? Or?
Yeah, Dr. Sadab is there?
Just describe it. I mean, we're not asking for a diagnosis here.
Dr. Sadab?
Yes, sir. Yes, sir.
Yeah. Yeah, please describe the lesion, mainly how it is looking and where exactly. And eyeball, you cannot say it is displacement, but roughly you can say that also here.
This seems like a supraorbital mass, sir, which is protruding outside.
So I think when we describe something, I think it's important to start with the most obvious, in which you cannot be caught as being wrong, right? If somebody says this is a rhabdomyosarcoma with extraocular spread, that is debatable. We don't know. But what we know is this is the photograph of a young boy with gross proptosis in one side, correct? Up to this, there is no confusion. So then you say that, the proptosis is severe. One can see some chemotic conjunctiva inferiorly, but one cannot make out the globe. It seems to be tense because you can see that here it's shiny and the skin is stretched. So it can be inflammatory. It can be neoplastic. Beyond that, I don't think anybody will expect you to say. So derive from what is known to what is unknown. So what is known is very striking. So that your examiner cannot debate with you, cannot negate you at all. But when it comes to diagnosis, even the examiner, even I can't remember what actually this boy had. But you can have proptosis of this severe nature, and you should start from the known, what is obvious, to the unknown. Okay. So no examiner is going to ask you what's the diagnosis here, because they themselves can't. If two orbital surgeons come, they will debate about what it could be. So it's not that simple actually. So there are very few areas which are spotters. I think that's another point I wanted to make out, Dr. Ajit, that in ophthalmology, while we give a lot of importance to spotters, look, I made a spot diagnosis, I'm that great. Most of ophthalmology, most of examination is about meticulous technique, systematic approach, and then coming to a diagnosis. Diagnosis is the last. In mathematics, you don't get marks only for the answer. All the steps are important. So I think it's important to groom yourself to do the steps very well. Now we come to the examination. We showed a couple of very mild proptosis, one case, and some more severe proptosis, another case. Then we need to answer this question when we see the patient. Where in the orbit is the pathology located? Is it behind the globe? Is it above, medial to, lateral to, under the globe, or inferiorly, or all around? We don't know. So inspection has to be carefully done, and it provides a goldmine of information. We'll come to a few pictures where I'm going to ask questions. Palpation supplements the finding of inspection. If you find it stretched, for example, if you palpated the last severe proptosis child, you're going to have either tenderness or raise temperature, or you're going to feel a firm mass, right? So that supplements, that gives you some added information. Auscultation, as we mentioned, rarely needed. Now, can we have the next young student try to describe what they see in this and try and correlate with what we see in the picture? In this.
Ashmita Mishra.
Sir, there is a
Video on,
intraorbital
please.
mass.
Yeah.
Video on, please.
Sir, I'm trying to switch on the video, but
Don't
it's
worry,
not
don't
working.
worry. Don't worry. Go ahead.
Oh, okay, voice
Sir,
is
there
heard.
is a infraorbital mass that is starting from the maxillary sinus and it is protruding into the inferior floor of the orbit.
Okay.
And
Yes, tell me.
and it is appearing cystic.
Okay. Right. Some of this is right. I would have actually preferred if you had first described the picture, because I don't need to always show this scan. I'm trying to do it because then I want you to put 2 and 2 together, and then we don't have, eternity to go ahead with the topic. So I'm putting them together. But if I showed just this picture, still you would be, as an observant person, be able to tell me something about what you find.
Hypertrophy is definitely.
Sir, by seeing the picture, we can see that the head posture is erect and there is facial asymmetry. And there is the movement of the eyeball is upwards on the right side.
Yeah, we don't call it movement, we call it displacement. The right globe appears to be displaced upwards. I totally agree with you. Also, there is some evidence of proptosis. And what else do you see? If the sclera is seen a lot here, what do you call it?
Scleral show.
Sure. So there is inferior scleral show. There appears to be globe displacement up with some degree of proptosis. I think that much is fine here. And how it correlates. So if the globe is displaced up, we know that there's something pushing the globe up. In very few cases only is a mass pulling something, right? We mentioned about cicatrization or, some kind of metastasis like a breast carcinoma, which can be sclerous. But the vast majority, if the globe is displaced up, there's a mass down. If there's a mass in the medial orbit, the globe will go out. If there's a mass in the lateral orbit, the globe will come medially. And if it's a superior mass, the globe will goes down. So that's pretty much straightforward, okay? So in this, you would say that, and what is the structure inferior to the orbit? We know that it is the maxillary sinus, right? So there are many tumors in the maxillary sinus. There are fungal infections. So you could say that this mass which has expanded, Dr. Ajit mentioned about the bone, the floor seems to have been destroyed and it is infiltrating the orbit. So this could be a malignancy, or very rarely it could even be a fungal infection. Right, so the next candidate can describe this picture and then try to correlate it. And I'm not at all asking a diagnosis.
Dr. Manasa?
Diagnosis.
Dr. Manasa? Dr. Surabhi?
Hello. Yes, sir. We can see that there is a downward displacement of the globe in the right eye. Sir, so there can be so there is a lesion which is coming from superotemporally and it is displacing the globe inferiorly.
Sure. So I think there is a gross inferior displacement of the globe with proptosis. I mean, the proptosis is quite striking, isn't it? So there can be many things happening here. So something in the superior orbit is likely to be causing it. So we come to know that some superior orbital mass. So in an exam, you will get to palpate, right? You will palpate something which is cystic mass in the superior orbit. So I don't want you all to be guessing what it is. The patient had a history of injury, road traffic accident about 6 months ago. And slowly the proptosis kept increasing. So any slow increase, constant increase is not a tumor. Well, this patient had what is called as a hematic cyst of the orbit, wherein there's a lot of blood collected under the periosteum, and slowly the blood products degenerate, causing osmotic fluid to come inside, and the tumor grows. Like any tumor, it grows, but it is a hematic cyst of the orbit. So the importance of diagnosis is not so much, but the approach, I think you all are slowly getting that feel that you should be able to describe well, and then you will naturally come to a conclusion, which is correct. Yes, sir. Next candidate.
Debajit. Dr. Debajit.
Yes,
Dr.
sir.
Rishabh, Devajit is there.
Yeah, let's have a description of the picture and then you try and correlate with what's happening there.
Sir, there is axial proptosis, I think, sir, in the right eye with a mass seen in the temporal area beneath the upper eyelid.
Okay, fair enough. So I think there may be some proptosis. I find it a little hard to comment on it. It's easier to comment on the scan, correct? So you're putting scan and clinical together, which is fine. But the striking part is a mass or a swelling in the superiotemporal orbit. You know that what is the main occupant of the superiotemporal orbit, which is the lacrimal gland, right? So there is no gross deviation of the globe, at least in this picture. But when you see a mass in the superiotemporal orbit, unless proved otherwise, it is a lacrimal gland. Because if you see the anatomy, it is the main thing occupying that area. And in the scan, it correlates with a mass in the area of the lacrimal gland, in the lacrimal gland fossa. And there are many conditions which can cause it. In the more severe forms of lacrimal gland swelling, you may see that the lid is S-shaped. There's a typical S-shaped lid in some of these dacryocystitis, etc. Yes, sir. Now, next candidate could possibly.
Yeah, Dr. Rishabh. Dr. Rishabh. Dr. Nuzhat. Then Manasa is not there. Parbasha. Parbasha.
I think it's very striking findings, so nothing to, we're not asking a diagnosis. Just describe the picture, so that would be more than enough.
Sir, I think. Sir, I think there is a temporal displacement of the eyeball with a mass in medial on the medial side, probably maybe a dermoid.
Okay, fine, fair enough. I think this is pretty fast. I think you went in straight to the points which are important. There seems to be some kind of displacement of the globe, maybe down, maybe outwards. But one thing that you must remember is if the mass is predominantly anterior, it may not cause much of proptosis, because if it's behind the axial, behind the equator, it causes more predominantly proptosis. But if it's anterior, it may cause more of displacement. So some temporal or outward displacement is perfectly fine. It's a little difficult to comment because the palpable fissure itself is modified. The superomedial orbit, not hard data, but looks like it may be a child, based on the proportions. And medial angular dermoid is certainly one of the possibilities. Other possibilities, if you ignore the scan, would be things like a frontoethmoidal mucocele, which may come from the frontal and ethmoidal sinuses. So if they would. Sorry?
No. There is a disturbance, I think, audio disturbance, nothing else.
Okay. So location wise, I think all the students are clear that if you look at the proptosis carefully, inspection, try to sit at the same eye level as the patient so that all these displacements are easy to make out. Quantify it using two scales, vertical and horizontal, to see if it's 5 millimeter outward displacement or 5 millimeter downward or upward, and use an exophthalmometer about which we will come in a short while. So now we come to what is the nature of the disease. And I think one of the important things to know, the saying is that the eye does not see what the mind does not know. So I think for the mind to know, you must attend a lot of these CME programs, these dedicated teaching sessions, read your books, and that way the mind knows, and a knowing mind can guess the differentials. If you don't read anything, you will not know anything about what is happening in the orbit. It will remain a Pandora's box as well. There are not, and as I mentioned earlier, not many orbital conditions permit a spot diagnosis. So it's not like, aha, that's a spotter. No, it's meticulous approach will get you to your diagnosis. Right, now let's have the next candidate describe it and tell me the diagnosis as well in this case.
Manasa, I think she's there now.
Straightforward.
Sir, there is a proptosis seen in the left eye.
Yeah, proptosis is very hard to quantify. I mean, I would not bet any money on proptosis on this patient because of the location.
Mass is located
Correct.
over
There is a swelling. There's swelling. Possibly a mass is located in the
located along the medial canthus.
Okay.
Medial side. We can say that medial side.
You can see it's either in the superior medial quadrant of the orbit or below the brow, extending from the brow to the medial canthus. All these are variable expressions. None of them are wrong. It's your choice of how you go ahead and describe it. Okay, somebody who looks like, maybe young adult, possibly, yes, and smooth. And you can also go ahead and describe, depending on the time available with you, that there are no obvious erythema, there's no obvious, shininess. So it may have been something which has grown slowly. It's not a sudden acute swelling, like for example. Okay, so all those things you can describe in greater detail, depending on what strikes you at that point of time and what does the scan show.
There is a cystic mass present.
Yeah. And what kind of a nature is it? Well-defined cyst in the superior medial orbit in a young person with not very, very, very homogeneous kind of a appearance is likely to be a medial angular dermoid. Okay, so the diagnosis in this case, medial angular dermoid. The treatment is surgical, and usually, if well done, nothing recurs. Okay. Now, can somebody describe this and tell me the diagnosis as well?
Shatarupa, Dr. Shatarupa, not there. Then Surabhi Prasad.
Yeah.
Dr. Surabhi?
Yes. Yeah. So there is proptosis in the right eye. There is.
Where is the proptosis? What is the definition?
Conjunctiva.
No, where is the? I mean, proptosis is what definition wise? What is the definition of proptosis?
Forward protrusion.
Forward protrusion of?
So it is a forward protrusion of the eyeball, sir.
Where is the eyeball?
Where is the eyeball?
Can you see the eyeball here?
You try to describe what you are seeing rather than anything you
yes. Correct. Because the talk is on proptosis doesn't mean all patients will have proptosis. Okay. Sorry, it looks like?
So, see, it looks like a cystic eyeball, sir.
Correct. I think that's good. So you these can be spotters, right? So you have basically, we don't know the eye, right? I haven't seen the eye. Nobody can see the eye. There seems to be a prominent cystic swelling here in a child, unilateral. It's likely to be. So I think it's good in exams not to really put all your money, hedge a little bit and say that it's just keeping the age of the child unilateral. And, it's likely to be congenital because you can see very carefully when you observe that even the lids are not very well formed.
Yes.
Right. So it's not something that, allergic inflammation. The lids are also not well formed. So it isn't an orbitopalpebral cyst or a cystic eyeball with associated cyst. So we know so then they can take you on to further diagnosis or what is the embryology of the eye and so on and so forth. So these can be kind of spotters. If you know, please go ahead and tell the diagnosis and don't talk of the eye here because then they'll ask you what is the eye, where will the eye be? Will it be rudimentary? Will you take it out or not? Will you put a secondary, orbital implant? Orbital implant, would you put an artificial eye and so on and so forth? So I think the descriptions have to be pretty straightforward in some of these cases. Anyway, there's another patient who's got some typical findings, which I'll describe later. But first, let's have some candidate make an attempt.
Again, Shatarupa is Pankaj. Again, Pankaj, Dr. Pankaj.
Yeah.
Just describe it. So this is the inhibition I think we need to completely overcome. So it's like when you take a course for a FRCS exam or MRCS exam or a DNB or anything. So first thing that you need to overcome is this reluctance. Whatever you say, you will make a mistake, but then you will learn something about it, isn't it? So I think just go ahead and describe.
There is lid swelling in right eye with mass in nasal quadrant, मतलब medial side.
Right. So I do agree with the fact that there is some lid swelling, and what else I would describe is that there is some possibly subconjunctival hemorrhage, or there is a hemorrhagic swelling in the medial conjunctiva, and there is some subconjunctival hemorrhage or congestion on the lateral area. Beyond that, I think it's very hard to say. If you observe very closely, you will see that there is some proptosis, or there is some prominence of the globe. So if I give a next hint, maybe this is not enough to come to a diagnosis, at least at the postgraduate level. But I say that this person has had these recurrent episodes since childhood, and the mother says each time the child had a cough and cold, so she would get some swelling in the lid, some bleeding, some swelling here, or the eyeball would come out. So what is the diagnosis in that case? Very typical. History of upper respiratory infections worsening an orbital condition. What's the diagnosis? You will get these in your fellowship entrance exams. You will get it in your patients in the clinic. Anybody? Any of the Wonderful, wonderful. I think that's very good. Lymphangioma is absolutely the right diagnosis, very hard to treat. There have been some recent developments in treatment, but overall very challenging condition. So I'm happy that somebody could answer. I think anybody who can make it, we give first right of refusal to the candidate whose name is read out. But if the person doesn't take it up, then anybody else could answer. I think it's going to be good. Right, sir. Next candidate, next person, next student.
Dr. Jakia is there? Shadab.
Yes, sir.
Yeah.
Yes, sir.
Yes.
Just describe the slide. I mean, you will see this in your clinic when you independently consult patients in your post-graduation or later when you are registrars or young consultants. These are things you're going to see. So you should know what it is and what are the differentials.
Sir, this seems to be, sir, kind of chemosis of both the.
Where is the chemosis? Chemosis should be here. Most of the chemosis in any patient, the maximum chemosis will be inferior, right? Gravity related. Here it is superior.
Superior, sir.
Yeah, so this is not chemosis. Anybody else? I think it's open house. After the first person asks the question, doesn't get it, I think it's open house. And whatever you see, you can describe what is there. Better to make a mistake here than
from the lacrimal gland.
Lacrimal glands. Okay, so that's one of the possibilities, because bilateral lacrimal gland swelling. But when you have examined lacrimal glands, you look at the lacrimal glands or the palpable portion of the lacrimal gland. The next 100 patients you're going to see in the OPD, you will not see anything like this. There will be only a little pink swelling here, a pink mass here. So this is yellow. Dr. Ajit mentioned about yellow.
Can yellow be a lipodermoid?
Correct. Very good. Excellent. I think that's very good. Lipodermoid is a very good differential diagnosis. It can be bilateral, it can be unilateral, and it is the closest differential diagnosis to this is lipodermoid or dermolipomas. In addition, you see that this also is a deadly giveaway, right? So what are these? Xanthelasma. So is the patient a very young patient?
No,
yeah, it's one of the middle-aged, correct. So the person is likely to be middle-aged or elderly. There are xanthelasma on both sides, and on lifting up the lid, you see these prominent bulging yellow lesions. And the patient says they has not had it from before. It's been recently noted, wants a cosmetic correction for it. And these are basically orbital fat prolapse. Orbital fat prolapse, if you look carefully, there are some early bags, there are some dermatocalyces and changes. So this will be debulked surgically and the patient will live happily thereafter. Okay, so I think the age is important. If it is a younger person, unilateral, if there were a few lashes sticking out, then, or if there was a coloboma or we showed some preauricular tags, then that would be something like a golden hour syndrome, dermolipoma. But I think that's a very good answer in the sense that as a differential, you've named the closest one. I am sure all of you have seen a Hertel's exophthalmometer. So, I mean, in this class, I don't think we can go about how to do it, but I think it's very important. If your hospital doesn't have it, I think please motivate your faculty to buy this one for you, because it's very, very important in documentation. Proptosis, you know that it is based on this principle of reflection, and this red light and this red line and the red line have to be aligned. One thing that I find sometimes students making a mistake is that they keep both eyes open when they do this, whereas this is a uniocular test. You need to close one eye. You cannot shoot a bird by keeping both eyes open. Similarly, you cannot align two lines if you keep both eyes open. So when you're seeing the patient's left eye, you keep your right eye open and see a line, read off the reading, and on the other side, read off the reading in the same way. And the base reading is very important because on serial follow-up like thyroid eye disease, etc., you need to see it. So Hertel's exophthalmometry is very, very, very important. And, in the exam, you may be asked. This is simpler one's lewd exophthalmometer, which we use, very clinic. In every clinic, you can keep it. It's a very small piece of plastic. It's a little better than the scale. I mean, otherwise, scale is also a good thing to do. Now, sometimes in examination, you will find some very interesting, which gives a very big clue to the diagnosis. You've got some mild proptosis, middle-aged lady, and then when you look at the fundus, you say, what is this? So what is this? Anybody?
Neovascularization?
No.
Collaterals?
Collaterals.
Collaterals is there, but if you utter that word only, the door will open.
Yes.
Right? And what is the diagnosis? So what is the orbital pathology and what is this? So you'll get MCQs. I'm sure many of you want to enter fellowship programs after finishing. So I think you better start reading up all these things. Okay? Nobody? So these are called optociliary shunts. And the diagnosis is a meningioma. If you look at the fundus of a person, you see there is reduced vision, you see some pallor, you see mild proptosis, you see some fullness in the temporal area of a middle-aged lady, and you see this, you can say meningioma. And the pathologist is going to agree with you after the surgery as well. Okay, so that's optociliary shunts. Now we come to examination in orbital disease. What are the effects of the disease? So any mass can have a mass effect, displacement, compression, etc. There can also be functional effects like motor. For example, a mass which is preventing a particular muscle from working can have double vision. There can be sensory effects, and there can be secretory effects also. For example, the lacrimal gland is completely infiltrated by something, then the patient is going to have reduced tear secretion. Now, for example, this is a patient who reported with intermittent proptosis. So can somebody describe and tell me what could be a cause? Intermittent proptosis. I think that's the giveaway.
Varices.
Who is describing? Shashmita?
So there is a mass in the picture which is seen in the superomedial quadrant, and it is causing the displacement of the eyeball towards the lateral side.
Okay. Lateral and down.
Or
I would say
down and out.
Inferior. Down and out. Perfect. So the mass is superomedial, so the displacement is down and out, but the patient says typically that he's fine many times, but when he lies down or strains or bends forward or laughs or cries, it comes out. So what's likely to be the cause?
So capillary hemangioma.
No, capillary hemangioma doesn't cause that. Orbital varices is there. Usually orbital varices, low flow orbital varices. There is imaging also which shows some kind of a calcification. Some of these varices can get calcified. So this is a very difficult condition to treat because he's a young man. He has a lot of things to do and activity. And if after every activity, the eye bulges. But it's again very challenging to treat. Orbital varices are very low flow and they are positional and they are maybe intermittent. Later, they can become even worse than this. So that's a good. Whereas arteriovenous malformations or fistulas are pulsatile and they are not intermittent. They would be there most of the time. Now we come to examination to try to find out about any contiguous spread or origin from outside, because you know that things can start in the brain and come into the orbit, or start in the sinuses, come into the orbit, or condition which start in the orbit can go into those. So paranasal sinuses, nose, important from the history point of view. Please do not forget intracranial compartment, looking at all the history, and also on examination, if there is papilledema, etc., you will have to look at other aspects. And also never forget to palpate the lymph nodes in any patient with orbital disease, because that can be a giveaway. For example, you have proptosis, bilateral proptosis, middle-aged person with large lymph nodes. You may think in terms of a lymphoma as well, like this patient who had tuberculosis of the orbit along with large matted lymph nodes throughout the neck. Now, we have to, in orbital disease, we are not pure ophthalmologists. We need to have look at the eye in systemic disease. Is there systemic malignancy? Has the patient had a breast lump removed 10 years ago? Has the patient thyroid disease? Is there any diabetes? Is there any other disease which is there? For example, there is a condition of neurofibromatosis, etc. Granulomatous inflammation doesn't strike the eye alone. So whether there are any lung features, and then whether your pulmonologist is going to do a lung lavage or bronchial lavage and find out sarcoidosis and help you with the diagnosis, or you're going to help them by taking an orbital biopsy. So it's always a two-way street. Systemic infections can affect the orbit, we know that. And endocrine disorders, at least the common ones, including thyroid, and phacomatoses, we talked about neurofibromatosis. For example, can somebody quickly describe, now you've heard so many times about it. Yes, sir.
Yeah, Manasa, you can answer.
Sir, it looks
very
like
obvious.
capulate spots.
Right. So these are typical cafeole flat brown spots. Many of you may be having it if you really look carefully, but they become significant if they are more than 6 in number and more than 1.5 centimeters in size, and they tend to become more prominent. I mean, I would like to, at this point of time, tell you a short episode of a child with unilateral glaucoma who was referred from center to center with no diagnosis, and the only thing that had to be done was to lift up the child's clothing, and the diagnosis was all over the place. So please examine all patients with proptosis, especially if there's a clinical setting for leash nodules in the iris, and certainly for cafeole spots. That's very important. People do miss it. It's not something that doesn't happen. Somebody can quickly describe this and the diagnosis.
Yes.
Is anyone speaking? No.
Rishabh?
Everybody's tired, I think, right? This is very striking, right?
Bilateral,
very striking and very clear clinical diagnosis.
bilateral staring look.
Yeah.
Okay.
It is
With
thyroid.
scleral show.
No.
In a
First
middle-aged
describe the
women.
picture. Don't jump onto the diagnosis.
Bilateral bulged out eyeball, proptosed eyeball having scleral show in a middle-aged women. Probably
Which
maybe
scleral?
due to
Which scleral show? When you say scleral show, you should describe the
inferior, both
superior. Both, correct. Both inferior and
superior
superior.
and inferior.
Okay.
Probably maybe due to thyroid eye disease.
Sure. So I think, what are the other subtle features? I think some of you may be reading a little bit more than the others, and they should be able to tell me something more. I mean, there's so much to be told about thyroid eye disease. If I say it's not thyroid and the patient has got, let's say, Cruzen syndrome or Treacher-Collins syndrome, how do you say, no, doctor, you're wrong? What are the findings which suggest?
Sir, in Treacher-Collins syndrome, there will be mandibulofacial dysostosis. And if it is Cruzen syndrome, there will be craniosynostosis.
All right. Okay, fine. So, so this is not exorbitism. What I'm saying is, there's a term which I have not introduced till now, shallow orbits leading to prominent eyeballs, which you have seen in Cruzen's and Treacher-Collins, Cruzen syndrome, Apert syndrome. That's called exorbitism. I think that's something, again, it can be an MCQ or you can be asked in a viva. So exorbitism is shallow, bony orbit leading to apparent bulginess of the eyes. This is not that. So these are the lead signs of thyroid eye disease. Also, I'd like to point out that the lateral flare the laterally, the palpable fissure is more flaring. So this is very typical of thyroid eye disease. From this picture also, I can look carefully and say that there is no congestion over the insertion of the medial rectus and lateral rectus muscle, which also suggests that there's not very active thyroid eye disease. And also we can make out that the cornea doesn't show any inferior exposure changes, etc., etc. So you can derive a lot. The eye doesn't see what the mind doesn't know. So as you become better, as you read more, become finally a student, I'm sure you can pick up all these things very easily. Now, in terms of diagnosis, I think there was a question, this last diet of the DNB exam, in which they said, some long question on unilateral proptosis. Correct? So you need to see by age, by laterality, and different age groups have different diagnoses. So I think you should be thorough with all that over the next 1 year. So age is important. For example, a proptosis present at birth can be a teratoma, etc. Elderly proptosis, sudden onset, you would think in terms of metastasis. Unilateral versus bilateral, young, neonate, infant, young child, older child, adolescent, young adult, middle age, elderly. So all these, the spectrum of disease changes, and I think it's important that you know it. By sex also, you can diagnose some of the conditions like meningioma, for example, are commoner in females. Thyroid disease is more common in females, though interestingly, severe thyroid eye disease needing decompression is more in males, especially smokers. Then again, laterality, onset and course, we mentioned waxing and waning course in idiopathic orbital inflammation. Location in the orbit we just described. Nature of involvement, is it acute, subacute, chronic, and mass and functional effects. Now, can somebody quickly describe this picture and give me a possible diagnosis as well?
Surabhi, Dr. Surabhi is there? She will be there, I think. Dr. Surabhi?
Right. If there's no one, we'll quickly describe this. An elderly lady. She's got.
Sir,
yeah, sure.
It is showing edema of both the upper and lower lids of the left eye, along with chemosed conjunctiva with some hemorrhage, subconjunctival hemorrhage probably.
Okay, this is an elderly lady. This is not edema. See, these are fairly well-defined masses if you read it carefully. And here, for example, nobody would confuse this with, let's say, fat prolapse, right? Or with the bags, correct? So this is a fairly well-defined mass lesions in the superior orbit of both sides with some chemosis, etc. So bilateral involvement in the elderly, we need to look at, for example, lymphoproliferative conditions, granulomatous conditions. I think this lady also had a parotid gland, some kind of Mikulicz syndrome. I don't think I put the pictures here. But within the orbit, there is some bilateral lesions. And these can be, lymphoproliferative in nature, etc. In the elderly. We think more in terms of malignant conditions as well. Can somebody describe this picture and the diagnosis?
Manasa. Dr. Manasa?
Sir, in the right eye, the upper eyelid is very tense. And
okay, it's very tense. It looks tense, stretched out, little erythematous. You should describe the discharge sticking right there.
Bloody discharge.
Bloody discharge.
Bloody discharge. Okay, fine. I'll give all that to you. Does it look like just lid edema, or does it look like it's more solid than that?
More solid.
Solid. So there's some proptosis, there is some mass in the orbit. There's a very deadly giveaway when you look at the other eye. It's in the background. Anophthalmic, yeah. No. This is an anophthalmic socket. Yeah, anophthalmic socket in a young boy. This is a slide which has been there with me for 25 years. It's been asked so many times in the fellowship exams and revision exams and so on and so forth. Because in the background, if you look carefully, you will find that it's an anophthalmic socket with a proptosis in one eye. This is less commonly seen now, but this is a child who has had a retinoblastoma, enucleated. The second eye developed retinoblastoma. The parents didn't bring the child for care till it reached this kind of condition. Okay, so you need to look at clues sometimes, and when you look at clues, you will get them. Now we come to the diagnosis of orbital disease, which can be benign, malignant, it can be secondaries. Typically in the elderly, sudden onset proptosis, be careful, examine the breast, look at the history of prostate illness, lung cancer, so on and so forth. It can be vascular. We looked at some of the conditions which can be vascular. That can be, Valsalva maneuver. You need to make the patient bend, and Valsalva maneuver, varices will fill up. It can be neural in some of the neurofibromatosis and other conditions. It can be hematological. And one point to emphasize here is that sudden onset proptosis in a child can be because of at least two different conditions. One, leukemias, AMLs, etc., can present with proptosis. So the peripheral blood smear is a simple examination. Please do not start anything without at least getting a peripheral blood smear, a total blood count, because you may find a leukemia in the child. Also, if it's bilateral, you can have other conditions like neuroblastoma, etc., as associated with ecchymosis. Ecchymosis, bilateral proptosis in a child. So you need to look at those conditions. It can be congenital. We looked at something. Post-traumatic, we looked at the hematic cyst. Foreign bodies are also notorious to be seen. So these are some of the imaging helps us a lot, but it's not still the final answer. This is a PET CT, for example. You need to use technology wherever it is needed. And a PET CT will sometimes show you the areas of activity and metastasis. Now, what is the management plan in orbital disease is based on history and examination, urgent steps if necessary. For example, there is an massive orbital bleed, and the patient has got 10th orbit. There's a chance of compressive optic neuropathy. You may need to do a canthotomy and cantholysis to relieve the pressure. Imaging includes ultrasound, CT, MRI, other investigations like visual fields, VEPs, if the vision is very down, pathological examinations. You may need to refer the patient appropriately, and then medications and surgeries. Now, very quickly about orbital tumors. I think in this, we are not going to ask too many questions. We're just going to run through the slides. So orbital tumors can be two kinds. They can be well-defined and infiltrative. These are very important because well-defined tumors can only be removed completely with appropriate technique. Infiltrative ones can only be biopsied or debulked. So it's important to differentiate between the two. It is when we try to remove an infiltrative lesion completely that we end up with complications like ptosis, like diplopia, muscle damage, squint, and even loss of vision. Now, based on examination, like we described, there may be clues to a specific diagnosis, like thyroid eye disease, for example, or neurofibromatosis and an optic nerve glioma in that setup. Or there may be no clues. So in which case, we need to depend on the pathologist to tell us what it is. And the final diagnosis is always by the pathologist. People are very fond of calling the orbiter the Pandora's box, which will possibly sometimes bring up surprises. So it's important for the pathologist to be involved with the care of the patient. And of course, we need that there's an intraconal space, there's an extraconal space. These are very important from the tumor point of view. Subperiosteal mainly from the abscess point. I'm sorry for the spelling here. And then, of course, the subtenons. Now, based on surgical approaches, we will very quickly run through. The anterior orbital approaches are for lesions in the anterior orbit. They may even be preseptal in some cases, with part of it being postseptal. Medial orbital approaches are for medial orbital tumors. Inferior orbital for inferior orbital tumors. Lateral orbitotomy, lateral orbital approaches are for intraconal and even apex. So the lateral orbital approaches afford the best exposure because you can remove the bone and then you can go in and you can go in right up to the apex. And if you want to do any work there and remove a tumor, you can do that. And of course, superior orbital approaches. So overall, we do look at orbitotomy approaches as being transseptal skin approaches. So we'll have I think we have a slide at the end of this part of the session, but I think in terms of time, we may not be too well to go on to the second part of the talk. So we'll possibly at the end of it, wrap up with some amount of discussion. There are transconjunctival approaches. There may be endoscopic approaches predominantly for the medial orbit and neurosurgical approaches wherein there is some kind of a mass, for example, optic nerve glioma going into the canal and going into the chiasm, where as an orbital surgeon, I work along with my neurosurgeon colleague to try and do an orbital transcranial approach, which gives better exposure. So this is one composite, and which shows some of the approaches. For example, the medial skin approach, and there can be a Lynch approach here. These are basically modified Stallard right. There's a Berkey incision and the lazy S incision. You can split the lid, for example, the upper lid into two, get into the superior orbit, remove the tumor, and then put the lid back together. So there are many. There is a subciliary approach, which is about 2 millimeters away from the lid margin, and it's again aesthetically a very good approach. You can have infraorbital approaches. So all these approaches, I think we will try and cover in a later talk, which possibly can be some other time. So I think I would request all the panelists to help me to sort out this presentation in terms of any other inputs or things that are important from the postgraduates from their exam point of view, and also from the practice.
Yeah, the second part, I think we can take another 1 hour some other day. I will inform you.
Sure. That's why I split it up.
Yeah. Let the postgraduate get the best out of the whole subject.
Correct. Sure. So if any of the panelists would like to add, like Dr. Anirban or...
So with Dr. Bigya, now initiate the discussion.
Yes, sir. So it was a very wonderful discussion with very striking photographs, with very nice spotter. There were some spotters also, and like he said, history taking is very important, and the steps how you go through while describing the mass, and how to describe a CT scan is very important for the postgraduates in their level now. Like they should explain in a stepwise approach, and so I would like the panelists to add if any points, or else.
Hello, I am Anirban.
Yeah.
Good evening.
Speak.
Yeah. Am I audible?
Yeah.
Yes, sir. Yes.
Yeah. So, first things first is Dr. ERM has done a fantastic job in covering the entire gamut of orbital disease spectrum in this lecture, which can actually go on for hours.
Yes.
But some of the highlights, one is that when our students were trying to describe these pictures, what one could make out is that they were faltering. Please, the first thing is don't be scared. I mean, the simple things like when you're describing a picture, you talk about which eye. Don't get biased. Don't jump. Don't look at the scan first. That is what he said right at the beginning, right? So nowadays, when we see patients, students run to see the scan. But I think the beauty of working in the orbit is knowing that there is a scan there. But first, you test your powers of deduction by doing a thorough history taking and examination. Okay. That would test your abilities to catch a diagnosis. Of course, the scan is there. You can go to the scan, but that comes in the end. So when you were being shown a picture, for example, just describe what you're actually seeing. Which eye is it? We were talking about proptosis when there were no proptosis, right? When there was a swelling in the anterior orbit. So, okay, what you describe, you see a swelling. What is the location of that swelling? Is there any color change over the swelling? Right. If there are any prominent vessels, like the last one he showed where he had the orbital retinoblastoma, there were prominent vessels that were visible in the lid. So just take care to describe actually what you're seeing. That would be of great help in coming to a diagnosis. All right. I don't see what more you could have added, except maybe changes. So you showed xanthelasma, right, where you showed yellow lesion. Maybe you could add a blue lesion or a red lesion where you have a capillary hemangioma or a deep capillary hemangioma.
Absolutely.
So this was wonderful. Very nice collection.
Thank you. Thank you.
Hello, Joyita here, sir. Sir, thank you, ERM sir, for this extensive lecture on approach to proptosis. This is for sure it will not benefit only our PGs, but also it's very helpful for us who are practicing ophthalmology in day-to-day life. So we have covered all the this difficult subjects so lucidly that I'm sure the PG will be little smarter in their approach in the next upcoming exam. Thank you, sir.
Thank you very much. Thank you.
So, Varsha? Yes, you're silent. You're muted, please. You're
Unmute
muted.
yourself. Unmute.
Yeah.
Hello. Yes.
Yes.
That was undoubtedly a very wonderful lecture. Actually, it was so simple and systematic. So each and every person could, I think, must have benefited so much. Thank you so much for the wonderful talk, sir. And
Thank you, Dr. Varsha.
really a gold mine of representative cases, which really put across all the basic things that one has to know as a postgraduate. It was a good revision for all of us. Thank you, sir. Thank you.
We have Dr. Rajesh also.
Dr. Rajesh is not well.
Is not joined.
He called up Dr. Subudhi to inform that he is not keeping well.
Yeah.
Which is why he couldn't join the meeting today.
Okay.
So I just wanted to ask few postgraduates. You know what is the 6 P's of proptosis?
Yes, ma'am. In the evaluation of proptosis, the 6 P's indicate pain, then progression, pulsation, and palpation. Ma'am, I know only these 4.
Anybody can add it? Add another 2?
Pain, any periocular changes if it is present?
Periobital changes. Right. I think when sir will be dealing about clinical approach to the orbital tumors, he will be describing in details with other examples where all the periobital changes can be seen. So I just wanted to ask Ravindra Mohan sir, so how do you approach any case of vascular malformation? Because that is one area which is very less, it is very less written in the literature. And clinically also, we find it difficult how to approach to them and how do you manage them?
Right. Now, in terms of vascular malformations, I think the important ones which we see in clinical practice are capillary hemangioma in the younger child, predominantly of the eyelid. So it's not so much usually in the deep orbit, but in the eyelid with the risk of amblyopia, etc. So, the perception of and the constant awareness to prevent amblyopia and active treatment by either intralesional steroid injections, oral steroids are very less used, or topical beta blockers, or even systemic beta blockers based on the choice at that point of time. So prevention of amblyopia is a first, second, third, and 10th priority there, because by age of 5 years, these capillary hemangiomas will disappear, leaving only a densely amblyopic eye. So we need to be aggressive in terms of management. Now, the other one which I showed, a lymphangioma, used to be the absolute bugbear of orbital specialists, because they could never treat them well. But of late, some exciting developments have happened, which includes injection of bleomycin. Because they are so disfiguring that the patient may sometimes even think in terms of suicide, because the eyelids, the conjunctiva, the orbit, everything is so disfigured with repeated episodes. And any surgical treatment used to only scratch the surface. So, in terms of, the interventional neuroradiologist also is unable to offer too much because it's so infiltrative. And also the cosmetic effect would always be poor, even if there are no new bleeds into it. But with the availability of bleomycin, there have been some fantastic results, including the ones which I have treated, wherein the cosmetic effect, the regression, and the lack of recurrence further has been very good. So there are some areas where things are improving. For example, lymphangiomas, the capillary hemangiomas, topical therapy, so that you don't have to take them up for intralesional injections under general anesthesia, and you can try to treat them with the topical beta blockers, or even systemic if your setup permits it. Some of the other ones we need help from other specialists. For example, the interventional neuroradiologists are able to do coiling, but those are in selected cases, coiling and all these interventions do run the risk of loss of vision. So sometimes they have to be very, very experienced to choose the right patient and do the right surgery. Surgical interventions can only be done after you reduce the blood flow. For example, they use different glues intravascular into the vein, multiple punctures, they thrombose the vessels, and then you can debulk within 72 hours or even later. So there are many exciting developments happening, and some of these multimodality treatments do tend to help. Exciting things include topical beta blockers like timolol for the capillary hemangiomas and intralesional bleomycin for lymphangioma. That's the next big thing. I mean, it's not the next, it is already a big thing, many parts of the body, but even in the orbit, it seems to be working well. Maybe I'll put up a couple of slides for the next talk to show what kind of results can come. So it's not about the surgeon, but it's about the modality. So that's.
And examination for Bruy.
Yes, sir. Bruy again. Yes. So if there are arteriovenous malformations, for example, wherein we find that the veins have arterialized, there are big swollen snake-like swellings on the lid, and the orbit also is a little, pulsatile proptosis. So we do ask candidates that how do you look at pulsatile proptosis? You may see it by torchlight examination, but otherwise when you do an applanation tonometer, you will find that the C's are moving a lot compared to the normal, endpoint of applanation tonometry. So that widened pressure pulse, and in that kind of a situation, one can use always the bell of the stethoscope and put it over, and one can hear the Bruy. Commonly, where we will always see, and once in a while we do come across patients with high flow keratoco-cavernous fistula after a road traffic accident. Those are very good for candidates to go and go to the neurosurgery ward or wherever these patients are, or even in the ophthalmic orbit OPD.
We have seen many
many fistulas. High flow ones will have a Bruy. Moderate flow may have. Low flow ones typically don't.
Prominent conjunctival vessels usually lead to suspicion of keratocaverous fistula.
Yes.
And further confirmed by the Bruy or pulsatile nature, which can be MRI angio can be helpful for confirming it.
Or a digital subtraction angiography,
Yes.
And then the neuroradiologist takes over from there.
So in this context of keratoco-cavernous fistula, so do you have any experience of doing a direct superior ophthalmic vein cannulation?
Yes, wonderful. Yeah, that's again something that's very, very. It's a good question. It's again, I was closely associated with Professor Santosh Joseph, who's a very well-renowned interventional neuroradiologist in the south of India. And he was with Chitra Tirunal earlier, then he was with Ramachandra Medical University here. And he once called me up saying that whether I can help him to cannulate the superior ophthalmic vein as an orbital surgeon. So I did go over and help him in 2 or 3 cases actually. Because as an orbital surgeon, we know the anatomy well, and these superior ophthalmic veins are hugely dilated. So you just need to remember the relationship with the levator muscle, the superior rectus muscle, and how they traverse medial to lateral. So once you search, it can be easily seen. Once you see it, our interventional neuroradiologists are good at cannulating anything. So we need to just go in, expose, and which is not very difficult. And they have a lot of advantages in doing the superior ophthalmic vein approach to CCF. From there, they can go in and coil. So they use platinum coils. And, it's like magic on the operation table, on the procedure table, in the cath lab, everything reverses. So but it takes time. So I have limited experience. I have not done it for quite some time now, but yes, it's a good procedure.
Yes, I think. So I think we had a good discussion. Anything left? Any postgraduate students? Do you
Left is for
want to
next
ask any
class.
questions?
Whatever left is for next class.
Yeah, we'll be having next class. Maybe after
We'll have
1 week.
ERM one more time.
Sir, I
Sir,
have a
made
doubt.
this
Very
session
pleasant
very
day, ERM.
interactive.
Yes, Dr.
Sir has made the
Prabhasa.
session very interactive.
Very nice,
and
very nice. No,
everyone.
I felt very happy listening to him, actually.
Yes,
I
yes.
was
Thank you
very
so
much
much.
involved with his lecture.
You are all very, very kind, sir. I think I enjoyed being a part of it, though it's I've done it much more in person than online. These classes, some of these classes, but I think
We
it's nice.
want
I'm
to
sure
give the
people will
benefit to
gain.
all the postgraduates of East India.
I did publicize this in among the postgraduates that the hospital at I go, and I'm sure there are some of them watching. I need to, if not live, they'll always access it later as well.
Okay, BNR.
Okay, then. Yes. Last but not the least, thank you very much, Dr. ERM. I think it's a wonderful talk.
Thank you, sir.
And
Thank you.
we enjoyed the
Enjoyed
talk.
being here.
But one thing I marked that all the postgraduate students, when we ask some questions, they describe the lesion, they suddenly jump to the diagnosis.
Diagnosis. We should
As
prevent
vividly
that
told,
tendency. Yes.
yeah, as
Yes.
vividly told that they go step by step, and everybody jumps to the diagnosis and they tell the diagnosis. So that's the one thing I observed from everybody. So, dear postgraduates, don't jump to the diagnosis first. Go on, examine the patient. So, I think it's a wonderful talk. I thank our president, Dr. Pranav Ranjan, mentor Dr. Ajit Babu, and Dr. Jayant Bora, our incoming president, all the panelists, and the moderators and the postgraduate students. You've done a good job today. All the postgraduate students who participated. Thank you very much, all of you. Last but not the least, Mr. Rahul and our platform provided, Enter Pharmaceuticals. So these words we close today. We'll move on to maybe next week or next fortnight we'll meet once again. Thank you very much. Good night.
Maybe a month's time, Ravindra Mohan. We have
Sure,
two more weeks. I have fixed up another speaker.
No problem.
Month's time from
Whatever
now.
it's convenient mutually.
Yes,
Yes.
Right.
And finally, thank you, word from the President EIZOC for a wonderful talk, ERM. It was really
Thank you, sir. Thank you very much. Thank you. I really enjoyed being a part of it. Thank you. Good night.
Okay, Rahulji,
Thank
you
you,
can
sir.
close down.
Okay, sir. Bye-bye. Good night.
Okay. Thank you, sir. Have a good
Thank
night.
you, everybody.